First question, our hospital staff has noticed that babies with mothers on glyburide seem to have more problems with hypoglycemia. Does the research support this observation? If so, would it be better to use insulin in most gestational diabetic patients like we used to?
Thank you so much for the question. That is a question that I've gotten in the past, and I actually, along with Dr. Moore, published a study where we looked at what is really the main factor in the development of neonatal hypoglycemia. And when we looked at medication dosing, there were no differences between glyburide and insulin. It appears that being-born LGA or macrosomic is what triggers the neonatal hypoglycemia. My concern is that most centers use glyburide BID, and I am a little concerned that that doesn't lead to optimal glycemic control because, as Dr. Hebert showed us, really the glyburide concentration in gestational diabetic is lower than that of type 2 diabetics. So I think we're underdosing glyburide. So my concern is that if you're using glyburide BID, you're actually not getting as good control as you would with insulin. UCSD says we use targeted dosing for glyburide, we tend to get pretty good glucose control, and so we're not seeing that higher rate of neonatal hypoglycemia in our infants going to glyburide. At least that has been my experience.
Thank you. Next question. Now that there's approval for the use of Levemir in pregnancy, have you started using it yet? And if so, do you see a difference or benefit versus NPH insulin?
I've just started using Levemir, so it's a little bit early for me to really give you a good, clear perspective. I know there's some good data out of Germany with the use of Levemir for type 1 and type 2 diabetes, but I must say that I've just started using it in some of my patients, so that interested.
Thank you. Regarding the type 1 boluses, does that mean that that you're just doing 2 injections a day?
Generally speaking, I have patients inject insulin in the morning, Humalog to control the post-breakfast, postprandial value, and then NPH at the same time to control their postprandial lunch values, and then Humalog again at dinner time, and then NPH after 10 p.m. So they actually inject a total of 3 times during the day, and then sometimes I add another dose of Humalog for lunch, depending on if I note that their pre-meals are actually very well controlled, but if postprandials continue to be a problem, then I add Humalog at lunchtime.
To control the fasting, the FPGs, is that 10 p.m. to 12 a.m.? Or what do you mean not at bedtime?
Exactly, because most people go to bed. Well, it depends on what time they go to bed. I say not bedtime because I want them to just be specific with the patient, to instruct the patient to give themselves the insulin after 10 p.m., especially for better experience after that. I've even had patients set alarms and give themselves the insulin maybe as 12 to 1 a.m. because not every patient follows a rule that they're going to develop hypoglycemia at 2 to 4 a.m. And so sometimes it's a little bit later or earlier than that that have them different age depending on findings. These are key hypoglycemia times in the early morning hours.
Okay, next question. Do you prefer 1 hour or 2 hour postprandials?
I prefer 1 hour postprandial. The reason is my mentor, Dr. Moore, taught me that with a 2 hour postprandial value, you might miss the actual peak of hyperglycemia that occurs after meals. And so in order to really treat that peak hyperglycemia time, I tend to use the 1 hour postprandial value. And so since I believe in that, that's what we've been using to really try to have the best neonatal outcome we can.
Thank you. Slide 17 for insulin distribution is not on the handout. Will it be available on the archive? And yes, it will. I will put all of the last set of slides will be on the archives. Next question. Do you use reduced carbohydrates for your gestational diabetics? For example, less than 20 grams at meal and none at snacks.
Yes, and I didn't go through uh, the diet counseling that usually happens um, before we initiate anybody medication. We do instruct them on a carb-limited diet. Um, and then usually on this carb-limited diet, they're going to be um, and if they fail our diet, then we initiate medication either for our
Okay, thank you. What is the best time for Lantus administration? I was taught QHS but have seen QAM too.
Actually, I've used both, and sometimes I've even had to do a PID depending on the patient. Um, like I said throughout my presentation, I tend to use Lantus more commonly in type 2 diabetes. I know that doesn't make as much sense since most of our patients with type 1 diabetes influence on Lantus, but I have such a hard time managing the hypoglycemia in type 1 diabetes that I end up switching them to the intermediate acting insulin for those reasons.
Okay, thank you. Would you have patients with GDM on NPH at bedtime check their blood sugars at bedtime also?
It depends on what the patient is reporting. If she's reporting some issues with um, hyperglycemia after a snack, for example, I have some patients who check after their bedtime snack, or if they're having some severe hypoglycemia, then symptoms that are waking them up, then I usually have them check at bedtime as well. But in general, I feel that with prescription diabetes patients, I have them checked faster than when I was prescribing.
Thank you. Do you recommend insulin injections in the abdomen or the arms during pregnancy, and does the site matter?
I have found that site really does matter. I generally tell them to inject it in their abdomen because that's where we have most of our sub-Q fat deposition. We don't have as much sub-Q in our arms, and we have more muscle in our arms. And so, for example, if you have somebody who's using their arms a lot for work, their absorption may be higher than that in the abdomen and may not be as smooth. And so that's for those reasons I tend to let patients know to inject the insulin in their abdomen. Same thing for our pump patients. I tend to tell them to put the pump in their abdomen and not in their arms or their legs because I just see that the insulin absorption just really differs if it's not, if there isn't a lot of subcutaneous fat at the injection site.
Okay, thank you. So you would use glyburate before lunch. This would be a TID dose?
Yes, I do use insulin, or excuse me, glyburide TID.
Okay, good. Okay, we've got a couple of questions that came up after I put the slides together, so let me read those. Please let me know if you need me to read it again. Um, is there a 6-day insulin protocol that you recommend?
Yeah, so sometimes, as we've noticed, when a patient ends up with flu, like I went through, they can become actually quite hypoglycemic. So generally speaking, I have them increase their insulin by 20%, and I have them call me on a near daily basis so that I can make adjustments to their insulin. And I caution them that after they get through the illness, that they may end up with some hypoglycemia because we've needed to increase their insulin so significantly. I also caution them to use cough syrup that's sugar-free, since many of the cough syrups have a fair amount of sugar in them.
Okay, can you go over the tactical use of glyburide slide again? Okay.
And I can't minimize the GoToWebinar control panel, but here's a slide. So again, generally speaking, I start the dose based on maternal weight. So 1.25 if the mom is less than 200 pounds, 2.5 milligrams if they're over 200 pounds. I instruct them to take the glyburide about 60 minutes before a meal. In other words, an hour before the meal. for breakfast, lunch, and dinner. And again, increments of 1.25 to 2.5 milligrams to start. So, for example, in a mom who, let's say, has pretty good fasting values, but it always seems like her lunch and her dinners are elevated, then I instruct her to take the glyburide 1.25 if I'm going to start when they're under 200 pounds, an hour before lunch and an hour before dinner. And then I increase it by 1.25 to 2.5 milligram increments. Generally, I would say most of my patients I increase it by 1.25 milligrams. But again, I don't make changes but every 4 days because we need to let glyburide reach steady state in the maternal serum, and that takes about 4 days to see a difference. So if you don't see a difference in the first 2 days, I would wait 2 more days and then make another change.
Okay. Okay, next question. How high would you go on your insulin dosing for very insulin resistant patients?
As high as I can possibly get. Again, if I get over, if I'm giving a patient over 40 units of insulin, whether it be NPH or Humalog, I usually split it in half so that the patient ends up injecting the dose into two different sites. I've actually also used U500 insulin, which is highly concentrated insulin in our very insulin resistant type 2 diabetes patients who are overweight. And I've had good experience using medicine.
Thank you. Does Lantus make more sense than INH, I think that's wrong, NPH, for women who go to bed early and have high fastings?
Yeah, it probably does. But again, remember, Lantus doesn't peak, so it's going to potentiate the dawn segment hypoglycemia, so just be careful with that.